Hello, my name is Kathleen Haley. I'm one of the pulmonary and critical care physicians at the Brigham and Women's Hospital, and I'm going to give you a seminar today on prophylaxis strategies in the intensive care unit. I have no conflicts of interest to report. So, a lot of what we do in the intensive care unit is to try to prevent iatrogenic issues. And so we're going to go over several areas that can be effectively prophylaxed. These include deep venous thrombosis, GI bleeding, ventilator-associated events, lung injury, delirium, and ICU weakness, the benefits of early mobilization. We'll start off with deep venous thrombosis because it's one of the more important and frankly lethal issues that we deal with in the intensive care unit. It's very, very common in our ICU patients. Up to 33% of ICU patients in a medical intensive care unit for more than 2 days had evidence of DVT on lower extremity ultrasound studies. DVT and pulmonary emboli have both attributable morbidity and mortality. Asymptomatic proximal DVT carries a 13% risk of death at 90 days compared to 2% of patients dying without evidence of DVT. DVT and pulmonary emboli occur together. Approximately 10% of patients in the ICU with a deep venous thrombosis also had a pulmonary embolism. However, pulmonary embolism is not commonly suspected on clinical grounds. Greater than 50% of diagnosed pulmonary emboli were only detected on autopsy studies. So this is a serious problem, which prophylaxis can be effective and certainly is needed. One of the things that we have to do is always risk stratify because there are always harms in even prophylactic strategies. So you want to balance the harms, which are pretty extensive, of venous thromboembolic disease versus the harms of prophylactic therapy. There are scoring systems to decide which patients are at greatest risk. These are generally more commonly used in surgical patients, and there really isn't a risk stratification strategy right at the moment for medical critically ill patients. Some of the more commonly used scoring systems are given below. What are the risk factors for our patients in the ICU for DVT? These include immobilization. Many of our patients are in the ICU following a diagnosis of cancer, which is in and of itself a hypercoagulable state. In addition, some of the cancer therapies will also increase the risk of thrombosis. Being critically ill in and of itself is also a hypercoagulable state. Increased age, cardiac failure, respiratory failure, burns, trauma, recent surgery, all prothrombotic states, a recent stroke, and obesity doesn't necessarily have to be to the extent of morbid obesity. Even generally speaking, obese patients have increased risk of thromboembolic disease. In addition to patient risk, some of our care that we regularly do in the ICU poses an additional risk of thrombosis for our patients. Again, immobilization, which is frequently seen with mechanical ventilation, central venous lines, any indwelling catheter in addition to the routine central venous line that we put in the ICU, such as an ECMO line, dialysis line, any line will be a site for thrombosis. Increased sedation, which leads to immobilization, and of course, paralytics. To make the matter worse, even though this is an important problem, a lot of times in our ICU patients, we don't use DVT prophylaxis or we don't use it correctly. And this just magnifies the risk of DVT in our patients. In one study, or up to 16 studies, approximately 70% of patients in the ICU were on DVT prophylaxis. That ranged between 33% and 100%. However, that means on average, 30% were not, and at the lower range, up about 60% of the patients were not on prophylaxis. And even when we have our patients on prophylaxis, we frequently disrupt the prophylaxis, which of course decreases its effectiveness. These interruptions are caused by procedures, intercurrent bleeding, and coagulopathy. Some of these interruptions are absolutely needed if you have a GI hemorrhage, say, but some of these can be avoided, and we should try to minimize interrupting our DVT prophylaxis whenever feasible. There are ways and strategies that are effective in increasing compliance with DVT prophylaxis. These include printed guidelines, and now that we have electronic health records, emails, electronic decision support, all of these are very, very effective, and that's really, really good news. Because increasing compliance with DVT prophylaxis will lead to decreased DVTs leads to decreased pulmonary emboli, and less morbidity and mortality for our patients. So, what are the regimens that we can use for DVT prophylaxis? The major reference for this that I'm using is the American College of Chest Physicians Guidelines, the 9th edition. This is regularly updated, but this is the most recent version. There are pharmacologic strategies, both for medical and non-orthopedic surgical patients. These include low molecular weight heparins, unfractionated heparins, and selective 10A inhibitors. Additional pharmacologic approaches can be used for orthopedic surgical patients who have a particularly high risk of DVT. These include direct thrombin inhibitors, although this is an off-label use for dabigatran, additional selective 10A inhibitors, including apixaban, rivaroxaban, and of course, some of the patients for orthopedic procedures just use warfarin with a therapeutic INR target range. All patients can be used for mechanical prophylaxis, and these include compression stocking, compression boots, venous foot pumps. The goal is to use these techniques at least 18 hours every day. Less is much less effective. Mechanical prophylaxis is effective, but it is not as effective as pharmacologic prophylaxis and can cause skin problems. However, it has the benefits is that there generally is no bleeding associated with the mechanical prophylaxis, and it can be a useful adjunct to the pharmacologic method, particularly since with procedures and coagulopathy issues, the pharmacologic methods are so frequently interrupted in our patients. So a common question that comes up is, what about substituting a regular antiplatelet agent since so many of our patients are on aspirin? Antiplatelet agents do have a decreased risk of thrombosis compared to placebo. However, they are generally less effective for prophylaxis of DVT compared to the regular pharmacologic prophylaxis strategies, and they carry the increased risk of bleeding. So at this point, they are not recommended for routine prophylaxis strategies in the medical ICU patients. So let's go over a couple of specific regimens. The low molecular weight heparins have some advantages over unfractionated heparin. It's fewer side effects, less risk of HIT, and also a more convenient dosing schedule. They are effective. However, they are a bit more dependent on renal clearance. This will vary among the exact low molecular weight heparin agent, and it's usually not weight-based, which can be a difficult issue to manage in the morbidly obese patient. Your pharmacy can help you adjust your dose as needed for the morbidly obese patients. Specific examples, in addition to enoxaparin, include dalteparin, and this has less renal clearance than enoxaparin. The PREVENT trial showed that it had similar effectiveness, decreasing DVT by 55% compared to placebo. The adverse effects were similar to placebo, and with creatinine clearances of less than 30 cc's per minute, there was no evidence of accumulation with a routine dosing. In addition, this has also been tested in patients greater than 75 years of age and had a satisfactory bleeding risk similar to placebo. Unfractionated heparin has a very long track record of effectiveness and decreases DVT by approximately 60% compared to placebo. It can be used twice or 3 times a day. The 3 times a day is somewhat more effective, but you do get increased risk of bleeding with this regimen. The nice thing about unfractionated heparin is that it can be used easily in patients with renal failure. There are associated complications. In addition to bleeding, there is a 1 to 2% of heparin-induced thrombocytopenia. Direct 10A inhibitors include fondaparinux, rivaroxaban, and apixaban. These can be used as an off-label use for HIT patients, and they are effective. Fondaparinux was studied in the Artemis trial and showed a 46% decrease in DVT incidence and a same risk of major bleeding, approximately 0.2% as the patients on the placebo arm. However, these medications do have renal excretion, and the FDA-approved indication is only for postoperative DVT prophylaxis and treatment of PE and DVT, and so use in medical patients or use for HIT patients is an off-label use. The direct thrombin inhibitors have been approved for patients with heparin-induced thrombocytopenia. The approved agents include lepirudin, which is available for subcutaneous injection. PTT is monitored for this. The problems with lepirudin is that you can get serious allergic reactions and anaphylaxis, and you can get an antibody to antihuridin in up to 40% of patients, and the antibody will delay clearance, which will affect any problems that you may have if bleeding does develop. It is also renally excreted, which can be an issue. Argatroban has only IV administration and again is monitored with a PTT. It has hepatic clearance, even hepatic congestion, so that can affect its clearance significantly. However, it's not renally cleared, and so it can be a good option for patients with renal insufficiency. Of note, the assay and the medication will interfere with the INR assay, and so you'll get a falsely elevated INR assay on patients with argatroban. The INR is not reliable, so it's not only an interference, but it is not a reliable number. There are oral agents that are direct thrombin inhibitors. However, they are not FDA approved so far for DVT prophylaxis, mostly because of the very limited clinical experience so far with these medicines that may be expected to change over time. Some patients are particularly problematic for DVT prophylaxis. These include, as we've alluded to, patients with renal failure. The low molecular weight heparins are renally cleared, and so the unfractionated heparin is generally preferred. And as we talked about, dalteparin has been studied in renal insufficiency. Morbidly obese patients also deserve special consideration. These need weight-based adjustment, usually the actual body weight, not the ideal body weight. There's also a different proportion of lean body mass to fat tissue, and so the pharmacologic clearance can be altered in these patients. Please note that if enoxaparin is used in morbidly obese patients, a twice daily schedule is more effective than the usual daily schedule for the non-morbidly obese patients. Coagulopathic patients also deserve special considerations. Abnormalities in coagulation due to uremia or hepatic dysfunction are risk factors for bleeding. However, they are not protective regarding DVTs. Therefore, medical patients with coagulopathies and thrombocytopenias are still at risk for DVT if they have other problems that are driving their prothrombotic state. Due to their increased risk of bleeding, however, mechanical prophylaxis may be the best option for these patients. Patients with GI bleeds, usually only 0.2% of patients on prophylactic doses of regimens will have any significant GI bleeding. And there is literature to support that even in the face of GI bleed, that pharmacologic DVT prophylaxis could be used. However, obviously, that will depend on the extent of the GI bleeding that is observed. Spinal anesthesia is also a special problem. There is an increased risk of spinal hematoma, and so again, mechanical prophylaxis is the preferred route for these patients. So let's move on to GI bleeding prophylaxis. the risk factor for GI bleeding in critically ill patient is abnormal GI mucosa. This is very, very common in up to 75% of our patients when they're evaluated by endoscopy. However, clinically important bleeding occurs in very few ICU patients, between 0.2 and 6% of ICU patients. The risk factors are mechanical ventilation for greater than 2 days, coagulopathy, older age, sepsis, including sepsis shock, steroid therapy, and multisystem organ failure. So the risk factors are very common among our ICU patients, particularly in the mechanically ventilated patients. There are several regimens that can be used for GI prophylaxis. These include histamine receptor blockers, either IV or enteral, proton pump inhibitors, again, IV or enteral. These may have slightly better acid suppression results than histamine blockers. However, they can interfere with other medications such as clopidogrel. This is due to the inhibition of the cytochrome P450 system because clopidogrel must be activated by cytochrome P450 to C19 in order to be effective. There is another regimen, sucralfate. However, this is not used very often anymore. It is a very thick slurry. It can clog tubes, decrease absorption of some enteral meds, and it's difficult to use in renal patients since this medication contains aluminum. And it's generally slightly less effective than either a histamine receptor blocker or a proton pump inhibitor, and so it has fallen out of favor. We're going to move on to ventilator-associated events. In 2013, the CDC changed the categorization of ventilator-associated adverse events to be a bit more objective. And so instead of prophylaxing for ventilator-associated pneumonia, the consideration has become a bit more broad to prophylax for ventilator-associated events. Ventilator-associated events include ventilator-associated pneumonia, which is diagnosed by 2 days of stable or decreasing ventilator settings, followed by at least 2 days of worsening ventilator settings. Subclassifications of infectious ventilator complications include the infection-related ventilator-associated complication, called IVACs, and possible ventilator-associated pneumonia. IVACs and VAP have significant morbidity and mortality in the ICU patients. They're fairly frequently seen, up to 28% of patients. They are associated with increased length of stay in both surgical and medical patients, and they carry a significant absolute mortality, up to 76%. Patients will pass away during their ICU stay following a pneumonia event, although that does depend on the virulence of the causative organism. And the attributable mortality can be upwards of 30%, meaning that the mortality associated with the infective agent, infective event itself is thought to be the cause of death in upwards of 30% of patients. Preventative strategies. You can use ventilator considerations, including the type of suction. The closed inline is almost always used nowadays because that will have a decreased risk of infection. There are some humidifier consideration. The heat and moisture exchangers are better than the heated humidifier. They should be changed weekly. More frequent changes are associated with higher infection rate. And the circuit changes that really doesn't affect the rate of infective problems, and greater frequency is associated with increased costs. One of the basic patient prophylaxis strategies is to reduce aspiration, because the basic mechanism of infection-related ventilator problems, IVAC and VAP, is aspirating infected secretions. So keeping the head of the bed up at least 30 degrees, using a measurement to define that 30 degrees can be very, very interesting and very effective, because guessing or eyeballing the 30 degrees is frequently inaccurate. Subglottic suctioning can be considered, however, it requires a specialized endotracheal tube. Maintaining an adequate, about 20 centimeters of water pressure, cuff pressure, but of course not exceeding 20 centimeters of water pressure to not cause mucosal injury. Avoiding nasotracheal intubation whenever feasible to minimize blocking sinuses, drainage, and maintaining good oral hygiene with teeth brushing and chlorhexidine can be very, very helpful. The use of IV antibiotics for GI tract decontamination remains a controversial strategy. Rocking beds can be used, but they again are extremely expensive and require specialized equipment. Of note, early tracheostomy has been tested to see whether or not it reduces infectious complications of ventilation. However, this has not been found to be effective. Ventilator-associated event requires a mechanical ventilation, and this is true whether it is an effective or non-effective problem associated with the ventilator. And so even though we invoke airway protection to justify mechanical ventilation, as soon as feasible, we want to remove the ventilator. And so daily awakening trials, daily spontaneous breathing trials to allow the patient to breathe on their own, use their own laryngeal reflexes as soon as feasible are the best way to prophylax against ventilator-associated events. Non-invasive ventilation for a very readily reversible etiology can also be a good strategy. And so basically try to remove the ventilator at the earliest possible opportunity. One question that does arise sometimes is what about the role of high gastric pH in the role of increasing the risk for ventilator-associated events? Gastric colonization does increase with decreasing acid. However, we require aspiration in order to set up the infection in the lungs. When the various techniques for decreasing acid production in the stomach were compared, there was a similar rate of infection with any of these strategies, whether it was sucralfate, proton pump inhibitors, or histamine blockers. And one can also aspirate infected secretions both from the oropharynx or from a sinusitis. And so that is a theoretic consideration, but as long as aspiration is minimized, it is not a problem to go ahead and use the GI prophylaxis in the ventilated patients as indicated. Moving on to talk about protective strategies for the lung to try to prophylax against lung injury. There is some new data to suggest that there may be strategies to prophylax against acute respiratory distress syndrome. Lung protective mechanical ventilation is an established treatment strategy in ARDS, and it may be useful as a preventative strategy. These studies are still relatively early. However, you can see evidence of damage from overdistension, barotrauma, atelectrauma, even with short-term ventilation. And of course, the risk versus the benefits must be balanced for the individual patient because a lung protective strategy and the low tidal volume associated with that may require an increased sedation dose. However, it is something that should be considered at patients who might be at risk for ARDS because using a lung protective strategy can be an effective way to prevent further lung injury. We're going to shift gears a little bit and talk about prophylaxing delirium, which is a very, very common problem in the ICU population. It's an important problem, even though a lot of times we take it in stride as just sort of part and parcel of the ICU care. It is an independent risk factor for death. Unfortunately, the role of prophylaxis is not yet clarified. The pharmacologic approaches have mixed evidence, and their use is controversial at this time. One of the issues that can arise is that early treatment of delirium can be effective, And frequently delirium is underdiagnosed, and so there is some confusion as to whether some of the pharmacologic prophylaxis is actually early treatment. But a true prophylaxis using a pharmacologic method has not been substantiated in the literature as of yet. There are several non-pharmacologic approaches to prevent delirium, and these have greater evidence. One wants to avoid exacerbating medications, particularly benzodiazepines, whenever possible. Also, good symptom control, including pain control, can be very, very important. Promote normal day-night cycles and normal sleep as feasible. And close monitoring for early signs of delirium, because again, it's underdetected and early treatment can benefit our patients. ICU weakness is another very common problem in our ICU patients. And it's not just deconditioning and immobilization. There is a distinct polyneuropathy and myopathy of critical illness that can take weeks to months to resolve. Some of this is medication related and can contribute to prolonged mechanical ventilation dependence and all of the associated morbidities associated with prolonged mechanical ventilation. Weakness, even when it isn't associated with prolonged mechanical ventilation, will nevertheless decrease the quality of life and will prolong a patient's convalescence. And similar to delirium, it is an independent risk factor for death. So can we prevent it? There are some recent studies suggesting that early physical therapy may be beneficial to prophylax against ICU-associated weakness. It is feasible and safe. However, it does require a very dedicated multidisciplinary team. It may be better for our patients, and so it is something that is still being explored, but more research is really needed to confirm both its effectiveness and whether or not it is really going to be a sustainable strategy. But there is some very interesting and encouraging data that perhaps getting our patients to move as soon as feasible may be very beneficial for them. Leading to the conclusion that exercise is good for pretty much everyone. To summarize what we've gone over, critical ill patients are at increased risk for venous thromboembolic disease, both DVT and pulmonary emboli. DVT prophylaxis is effective, but it must be used correctly. Histamine blockers or proton pump inhibitors are effective prophylaxis strategies for preventing stress ulcers and are the recommended approaches. The common denominator in ventilator-associated events is to avoid prolonged mechanical ventilation and to avoid aspiration. Environmental controls can decrease the incidence of delirium, and exercise is almost certainly good for everyone. So get your patients out of bed whenever possible. Some review questions. You've admitted a 68-year-old gentleman with sepsis due to a pneumonia. As part of his routine admission orders, subcutaneous heparin is started for DVT prophylaxis. He has required mechanical ventilation and pressor support. His laboratories included creatinine of 2.6, an INR of 2.2, and platelets of 95. What is the best option regarding his DVT prophylaxis? A, the subcutaneous heparin should be discontinued and mechanical DVT prophylaxis should be started since he has signs of a coagulopathy. B, the subcutaneous heparin should be continued. C, the subcutaneous heparin should be changed to enoxaparin since the patient has evidence of renal insufficiency. D, the subcutaneous heparin should be discontinued. No DVT prophylaxis is needed because he is autoanticoagulated with an INR of 2.6. Or E, the subcutaneous heparin should be discontinued and fondaparinux should be used for DVT prophylaxis. The best option here is B, the subcutaneous heparin should be continued. Question 2. A 68-year-old woman who has a prior history of GI bleeding due to peptic ulcer disease has been admitted to your ICU for urosepsis. The patient requires low-dose norepinephrine to maintain her mean arterial pressure above 65, but her hemodynamics have been improving with IV fluids. She does not require mechanical ventilation. Her past medical history is positive for both coronary artery disease and myocardial infarction, and she is on aspirin and clopidogrel following a coronary artery stent placement. What statement is true regarding her DVT prophylaxis management? A, the patient should receive either low molecular weight heparin or subcutaneous unfractionated heparin for DVT prophylaxis. B, since she is not on mechanical ventilation, the patient will require only DVT prophylaxis if she requires pressors for more than 48 hours. C, since she is on 2 antiplatelet agents, she does not require additional DVT prophylaxis. D, the patient is at higher risk of bleeding due to her history of peptic ulcer disease. Unfractionated heparin can be used as long as there is laboratory monitoring to maintain a PTT between 1 and 1.5 normal value. Or E, since she is on 2 antiplatelet agents and has a history of GI bleeding, she should not receive pharmacologic DVT prophylaxis, but could receive mechanical DVT prophylaxis. The best option here is A, the patient should receive either low molecular weight heparin or subcutaneous unfractionated heparin for DVT prophylaxis. She is critically ill and therefore remains hypercoagulable, and the use of antiplatelet agents will not be as effective as a DVT prophylaxis as the usual pharmacologic approaches of low molecular weight heparin or the subcutaneous unfractionated heparin. And her GI bleeding is a remote history, and so there is no reason to avoid using pharmacologic prophylaxis, and usually the PTT is not monitored for using low molecular weight heparin or unfractionated heparin when used at the prophylaxis dose. Question 3, a 55-year-old man with a body mass index of 40 has been admitted to your ICU with multisystem organ failure in the setting of a pneumonia. He is on mechanical ventilation and pressors, and his creatinine is 1.5. What is correct about his DVT prophylaxis? A, the risk of DVT and PE are such that full dose anticoagulation is recommended. B, either low molecular weight heparin or unfractionated heparin could be used for DVT prophylaxis. Routine fixed dosing schedules are effective. Because of their once daily dosing, the low molecular weight heparins would be preferred. C, either low molecular weight heparin or unfractionated heparin could be used with dosing based on ideal body weight. D, either low molecular weight heparin or unfractionated heparin could be used with dosing based on actual body weight. Or E, the increased risk of DVT and PE in the morbidly obese make unfractionated heparin unable to be used, in fact contraindicated. Only low molecular weight heparin, dose adjusted using ideal body weight, should be used. The best answer here is D. Either low molecular weight heparin or unfractionated heparin could be used with dosing based on actual body weight. Question 4. A 62-year-old man with COPD exacerbation due to pneumonia has been admitted to your ICU. He requires mechanical ventilation. He has been receiving DVT prophylaxis with unfractionated heparin. Last night, he had a 2-hour episode of hypotension following a turn. During that episode, his oxygenation requirements increased, but he subsequently has tolerated tapering his inspired oxygen back to 50%. Which of the following statements is true? A, since he has been on DVT prophylaxis, his risk of DVT or PE is extremely low and does not need to be considered as a cause of his overnight symptoms. B, since he has been on DVT prophylaxis with unfractionated heparin instead of low molecular weight heparin, he is at moderate risk for DVT or PE. C, although he has been on adequate DVT prophylaxis, he remains at risk since approximately 10% of patients with prophylaxis develop DVT and 10% of those patients develop pulmonary emboli. D, since his symptoms have resolved, his risk of DVT or PE is quite low. Patients on mechanical ventilations have poor tolerance for any further decrement in respiratory function. Therefore, PE is usually suspected on clinical grounds. E, although he has received DVT prophylaxis, his risk of DVT and PE remains high. He should be started on full-dose anticoagulation until PE is ruled out. The best answer here is although he has been on adequate DVT prophylaxis, he still remains at risk, and therefore PE should remain in the differential. However, it is not quite so high that he would automatically qualify for being covered with full-dose anticoagulation, particularly if he is considered to have a higher risk of bleeding. However, it should be evaluated since 10% of patients will fail their prophylaxis therapy, and 10% of those patients will go on to have a pulmonary emboli. If there is no other obvious reason for his overnight event, then full dose anticoagulation pending exoneration of pulmonary emboli should be considered. Question 5. A 45-year-old man with respiratory failure due to pulmonary edema in the setting of cardiomyopathy and renal failure has just been admitted to your ICU. On admission, he is on norepinephrine to maintain his blood pressure. He was intubated in the emergency room. Which of the following could decrease his risk of ventilator-associated pneumonia? A, keep the head of the bed elevated, use inline suctioning, add IV antibiotics for GI tract decontamination. B, keep the head of the bed elevated, change the humidifier circuit every week, proceed to tracheostomy if the patient requires ventilator support for more than 7 days. C, use subglottic suctioning, add IV antibiotics for GI tract decontamination, use inline suctioning, change daily. D, use subglottic suctioning, keep the head of the bed elevated, maintain oral hygiene with chlorhexidine rinses and swabs. And E, keep the head of the bed elevated, proceed to early tracheostomy if the patient requires ventilator for more than 7 days, use oral topical polymyxin B and IV antibiotics for GI tract decontamination. The best answer here is D, use subglottic suctioning, keep the head of the bed elevated, and maintain good oral hygiene with chlorhexidine rinses and swabs.